Say the mean time to surgery in most of the series is looking at the say take Soloway's data was about 4 to 7 months. Have people continued hormone after surgery for one year or 2 years like they have done in radiotherapy settings? Then it will be an equal match. So is there a data like that?
Not to the best of my knowledge. Do you panelists have any kind of comment?
Why can't that be studied is my question to the August gathering.
Absolutely. I think that from a clinical trial perspective.
So yes, if PSA has not touched biochemical control, probably in those series, but otherwise.
After radical prostatectomy, if you get T3, is there any role of radiation in this setting?
So adjuvant radiation versus salvage radiation. Last couple of points.
Adjuvant mostly, the world has moved on to in India also to salvage. For that matter, salvage means early salvage. So if the PSA after prostatectomy has touched, went undetectable, we can pretty well wait, and that salvage also needs to be not like we wait it goes more than 0.2. Even there are good data between 0.1 to 0.2 if you do, because the more you have a point increment, the failure rate increases later.
I guess the answer is
so early salvage is more or less the
if
norm.
it's a T3 disease, you still wait for the PSA to rise.
Basically, you have to understand also this patient already received the ADT. So this may not be the classical picture.
I thought you were talking in more general sense.
In this
you're talking about this mini case?
Yes.
Yeah, if you go for surgery, then radiation?
Yes.
I
so
guess
one quick thing.
So more unanswered
Sir?
questions. Dr. Raghavan will get the honor and the pleasure to wrap this up now.
You know, I just
The bell
wanted to
has
say what Abhishek said was very true. The problem with surgeons is that none of us continued the hormone therapy post. So we published a recent study of 30 patients neoadjuvant, and going forward, many of the patients are now completing 18 months and 2 years in our series. All of them had adjuvant therapy as well. We have 67 patients of neoadjuvant now. Hopefully, we will publish proper Indian data about neoadjuvant plus adjuvant in surgical patients.
So can I have one quick comment?
But I think the real answer of this question will come when we done a randomized trial. Even we are doing a neoadjuvant, and we are so, if we want to say that neoadjuvant works, we need to do a randomized trial where one arm will receive the standard and other will, because if you publish that, everyone will start using the neoadjuvant hormone. And that message should not go to that. So it's in a day-to-day setting, it's a different thing. In a trial setting, then we can prove that neoadjuvant hormone followed by adjuvant hormone works.
It's always great to end on a controversial note. So that's what we have done right now. Thank you so much, ma'am. I told you I'll stop when you tell me.
Thank you
Thank
so
you very
much,
much.
Dr. Gagan Prakash. I thank all the panelists and our esteemed chairpersons for engaging the audience in this postprandial state of mind. And we move on to the next session, which is on achieving best outcomes. For chairing this session, I invite Dr. Rajesh Bhatt, Dr. H.S. Pava, and Dr. Chirag Desai. And Dr. Rajesh Bhatt is a consultant urologist from MIB Super Speciality Hospital, Mumbai. Dr. H.S. Pava is a professor in Uro-Oncosurgery Department at King George Medical University, Lucknow. And Dr. Chirag Desai is a consultant oncologist and director, HOC Vedanta, Ahmedabad. May I request the speakers to please stick to the time which has been allotted to you. My request to the delegates that those who have not collected your delegate bags, please do collect it from the reception counter while they are still available and the counter is open. And I hand over the session to where are the chairpersons? Dr. Rajesh Bhatt, Dr. Pava, and Dr. Chirag Desai. Anyone present? Okay, may I ask someone else to chair? Okay. Dr. Vedang Murthy is going to chair the next session. So I'll invite the first speaker. This is a presentation of 3 practice-changing papers. Moderator is Dr. Ravi Mohan Mavuduru. He's a professor in urology from Postgraduate Institute of Medical Education and Research, Chandigarh. We have presenters Dr. Ravi Chandran, Dr. Rupesh Shah, and Dr. Manoj Tumala. You have 5 minutes for each presentation and finally 5 minutes for discussion. So my request to the presenters to please stick to 5 minutes to your case. First presenter, Dr. Ravi Chandran K, who's a consultant uro-oncologist from Apollo Cancer Center, Bangalore. Sir, you can please start. Meanwhile, the tea and coffee is being continuously served outside, so whoever feels sleepy can go and grab a cup of tea or coffee whenever you need it. Thank you very much.
Good afternoon, everyone. The first paper for the day is dose-dense MVAC versus standard GC as perioperative chemotherapy for patients with non-metastatic MIBC. Results of GETUG AFU V05 VESPER trial, published by Christian Fester et al. Team from French Urology Association. It was published in Journal of Clinical Oncology in May 2022. Well, they set out with an introduction stating that there's an absolute benefit of 5% on overall survival with a neoadjuvant chemotherapy in MIBC. However, the regimen, the dosage and protocol has been controversial. Well, in the wake of a couple of phase 2 trials showing role of dose-dense MVAC, this French group set out with a plan for a phase 3 RCT, randomized 1:1, to put dose-dense MVAC was a standard GC heads up. The inclusion criteria for this trial was pure or mixed TCC, clinical T2 to 4A disease, node negative, and an M0 receiving neoadjuvant chemotherapy, and any pathological T3, T4, or node positive or receiving adjuvant chemotherapy with a creatinine clearance of 50 ml per minute. And the exclusion criteria were any pure adenocarcinoma or a pure squamous cell or mixed or a pure small cell neuroendocrine carcinoma, and a patient with ejection fraction of less than 50% with history of cancer in the last 5 years, pregnant women, breastfeeding, and age more than 80 years were exclusion criteria. Well, the primary endpoint for this trial was progression-free survival at 3 years, and the secondary endpoints were chemotherapy toxicity, response rate, postoperative complications among patients who underwent cystectomy, time to progression, and overall survival. Well, between 2013 and 2018, across 28 centers in France, 500 patients were randomly assigned for the trial. In GC arm, after exclusions, 245 patients were evaluated, and in dose-dense MVAC, 248, and it was an intent to treat analysis plan. Coming to demographic details, there are two key factors which I want to highlight in this table. One is, in both the studies, close to 88 to 89% of patients underwent neoadjuvant chemotherapy prior to MIBC. When this study was set out in 2012, the practice of neoadjuvant was not so well established, but surprisingly, the neoadjuvant was well taken up by all these centers. That is one point to focus upon. And the second thing is, the pathological response, complete pathological response was seen in 36 of patients in standard GC, whereas 42% in DD-MVAC group of patients. Coming to treatment delivery, between the adjuvant and the neoadjuvant, majority of the patients, as we have seen, have undergone neoadjuvant chemotherapy. And to the right of here, there is a table showing that 66% of patients could complete 4 cycles of GC, whereas only 58% could complete all the 6 cycles of dose-dense MVAC. Coming to results, coming to pathological response, 42% of DD-MVAC had a complete pathological, contrary to 36%, and 77% in dose-dense MVAC had an organ-confined status, that is PT1 and less, compared to 63% in GC arm, and positive margin rates was 6 versus 5.6. Coming to the primary endpoint, that is progression-free survival at 3 years, as you can see, it's quite obvious. In the first one, it's an overall, combining both adjuvant and neoadjuvant. As we can see, though the DD-MVAC seems to be doing better than GC, it was not quite statistically significant, whereas in neoadjuvant group, the difference was very clear. And the progressions were observed for total 165 patients, 96 and 69 respectively for gemcitabine and DD-MVAC. And among these progressions, 64% and 67% were metastatic. Coming to secondary endpoint, time to progression, again quite clear, DD-MVAC does better than the standard GC group. Coming to final analysis, here there were three set of publications from the VESPER trial group. One was in 2020, where they have published data on secondary endpoints in chemotoxicity, and one in 2022, where they have published primary endpoint data. And recently in ASCO 2023, in an oral abstract session, they have given a 5-year overall survival data. So to make it compact and easy for us, I've combined all the three information and put up the presentation. Here, the final analysis at 5 years for overall survival and disease-specific survival, as you can see here, the DD-MVAC group seems to be doing better than GC group. And coming to secondary endpoint, the chemotherapy toxicity, 11 patients in DD-MVAC had to stop compared to 12 in GC arm. And if you focus the last one, the grade 3 toxicity, 52 of DD-MVAC had grade 3, whereas 55 in GC arm. I'll skip this. And compare it, as I mentioned in the beginning of the trial, there were a couple of phase 2 trials which showed the role of dose-dense MVAC in MIBC setting, whereas VESPER is the first phase 2 RCT in over last 2 decades to be done in MIBC space. And to conclude, VESPER trial is a milestone in the history of chemotherapy for MIBC. And in neoadjuvant population, PFS at 3 years was significantly higher compared to the overall group. And it provided a better OS at 5 years and significantly improved time to progression as well as disease-specific survival. There was no difference in pathological complete rate, but certainly higher pathological response rate was seen in DD-MVAC group. Though grade 3, grade 4 adverse effects, especially GI and asthenia, were a little higher in DD-MVAC. And the authors conclude stating that a neoadjuvant chemotherapy with DD-MVAC in clinical T2 to T4A disease node-negative MIBC setting can be a potential new standard of care. Thank you.
Yeah, thank you, Ravi. It was a very nice paper. So apparently, many of us are not interested in practice changing, it seems. Anyway, for those who are interested, this is a very interesting paper because it is telling that DD-MVAC, they have given 6 cycles versus 4 cycles, and DD-MVAC did show a good outcome in a neoadjuvant setting. So do we have any medical oncologists who are here who can share the experience of Indian setup? Any medical oncologists from our side who want to comment on the percolation of DD-MVAC with respect to GC? Because at least in PGI Chandigarh, we have shifted to DD-MVAC in majority of the patients, and the results are really reproducible as they are here.
So can
Ashwin.
I had heard Kumar Prabhas saying this in one of the panel discussions that it's because of the medical oncologists who are not using dose-dense MVAC because of potential query toxicities in their minds. That's been underutilized. In fact, they should be utilizing it more in NACT setting, considering this trial. That was his comments.
Yeah.
So hi, as a medical oncologist, yes, DD-MVAC is a very interesting regime, but in our routine experience, we feel cisplatin gemcitabine, the tolerance and the toxicity is so comforting. And most of these patients, are usually elderly, their PS is borderline, and they cannot afford a neutropenia or an FN. And the data showed that the quantum of FN and neutropenia was significantly higher in the DD-MVAC group.
I think that remains a limit.
Yeah, we also shifted to DD-MVAC, but only for selected patients. We assess the patients and selectively we give for healthy young patients rather than for old age.
I invite the next speaker, Dr. Rupesh Shah, who is Director and Consultant Uro-Oncologist from Icon Hospital, Ahmedabad, to present the next case. 5 minutes for your case.
Yeah. At the outset, I would like to thank organizers for the opportunity. The paper given to me is combination of ADT with radical local therapy versus only ADT in newly diagnosed oligometastatic prostate cancer. It's a phase 2 randomized controlled trial. The inclusion criteria for the studies are newly diagnosed disease, histologically proven prostate cancer without neuroendocrine differentiation, no previous treatment to the primary tumor. Oligometastatic were considered 5 or less bony metastatic or extrapelvic lymph node by using conventional imaging. And previously treated within 6 months of traditional ADT was considered in the study group. Those patients who have received chemotherapy, abiraterone or second generation anti-androgen were excluded in the study. Randomization done by simple randomization method by 1:1 in the both the arm. ADT with first generation anti-androgen were allowed in both the groups, but the Abi, Enza or docetaxel or cabazitaxel was not allowed before they entered into the CRPC. Resectable tumor were considered clinical T2 to T3B, and unresectable tumors are those who are involving the rectum, bladder, neck, or both. For the unresectable tumor, ADT was given up to 3 months, and they were assessed. If they are resectable, they were considered for radical prostatectomy. And pelvic lymph node dissection was optional in this study. And RT was given to all unresectable tumor or patients who refused for the surgery. And the follow-up of this study is the PSA and testosterone every monthly for 6 months, then every 3 months for 2 years, and then every 6 months. And imaging CT as well as bone scan every 6 months, or increased PSA or patients become symptomatic. The outcome were analyzed either radiographic progression-free survival, or secondary outcome was overall survival and PSA, PFS. If you see the chart, almost 200 patients were randomized, 100 in each arm, and out of that, in the study group, 85 patients received radical prostatectomy and 11 patients underwent radiation therapy. And final analysis of that, certain deviations in the protocol was there, and final analysis was 73 patients in the control and 92 patients in the study group. The baseline characteristic of these patients are median age is 68 years, median PSA is quite high, 99. Majority patients are of high Gleason's grade T3 as well as bony mets. Those patients who underwent surgery, majorities are open radical prostatectomy, bilateral pelvic lymph node dissection done in 60 patients, and out of which 26 patients had positive lymph node. And median number of lymph node resection was 6, probably less. 11 patients underwent RT, 7 to prostate and lymph node drainage both, and 4 only prostate RT was given. Coming to the complications of the surgery, that 24 patients total developed complications, but minor complications were in 21 patients, and 3 complications were pelvic hematoma, anastomotic stenosis, or rectal injury in higher complications. And urinary incontinence, 2 years data was only 5%. That are almost comparable to what we do in non-nerve sparing locally advanced disease. For the radiations, only higher grade complication in 1 patient had higher complication. Median follow-up was 48 months. If you see the radiographic progression-free survival are favoring the study group with a hazard ratio of 0.4. And at 3 years, study group has 76